Welcome to the Benefit Whisper, where we decode the nonsense of today's healthcare system and whisper the truth to those who want real solutions. I'm Ralph Weber, host of the Benefit Whisper, and today I'm joined by a data-driven voice for change in healthcare, Dr. David Scheinker from Stanford University. From unnecessary delays to misaligned incentives, we're unpacking the hidden waste that's costing employers, patients, and providers billions of dollars. David, welcome to the show. Why don't you
Thank you
start
for
by
having me.
telling the listeners just a little bit about yourself?
I started my research career as actually a mathematician working in theoretical math, and then changed careers into healthcare engineering, kind of based on a serendipitous opportunity to work on a research fellowship at an amazing joint group at MIT and Mass General Hospital.
Healthcare engineering, that sounds really interesting. I've never heard of that. I'm a data geek. Like, I just love, I used to be an air traffic controller years and years ago, so I just love numbers. They speak to me. They tell a story. So anyway, David, let's cut through the bureaucracy. What's the most egregious example of administrative waste that you've seen in your work?
So recently at Stanford, we've developed what's one of the most successful type 1 diabetes care programs in the world. It's amazing work led by doctors David Moss and Priya Prahalat, for which my team has built much of the technology. And our kids with type 1 diabetes are doing amazingly well. 1 and even 3 years after diagnosis, their glucose management and outcomes are on par or better than the very best clinics in the world in Sweden that are famous for great resources and a heterogeneous population. So we've been
Wow.
trying to scale this care. Yeah, it's an honor to be part of that work. You can read it about it in Nature Medicine most recently. But
Excellent. That's great.
we've been trying to scale that work, and there's already a predefined CPT code that we should be able to bill for this remote patient monitoring and digital medicine. And it took us a year, 1 year, to start dropping bills for the care we're already delivering, for the CPT code that's already been well defined and approved, with weekly meetings, physicians, compliance, certified diabetes educators, me, and many other people from all over the institution, just to build the ability to click a button and bill for care we deliver.
Wow. That's a lot of waste. And that kind of brings me to another question. So prior authorization, it's supposed to protect the system, but is it really doing more harm than good?
So, can't answer that, whether it's more harm than good. There are certainly far too many heartbreaking stories of people that have died, suffered
Right.
blindness, or other irreparable harm due to prior authorization. There are also stories of healthcare savings or for the prevention of low value or unnecessary care. It's not for me to say how those can be balanced. I'm 100% sure of is that the current system is far worse and far more complex than it needs to be, or than a system that would still achieve the benefits, but without many of the harms and delays as possible.
Right. Just last week, I spoke with Dr. Don Berwick, and we spoke about that somewhat. Don is, as you know, just a pioneer, an absolute brilliant pioneer in this area. And we had a very, very interesting conversation. Now, speaking about denials, you mentioned vague denials and that they're harder to appeal. How widespread is this? And you talked about some of the real life consequences again, but how widespread is a vague denial?
Yeah, so I'm sorry, I just want to, again, preface a little bit my answer by saying these examples that I'm giving, none of them are the root problem. They're all symptoms of the root cause problem of this complexity and lack of standardization. And to your specific question, at our children's hospital, Stanford Medicine, Stanford Children's Health, we provide incredible life-saving care, and then we submit a bill. It's itemized. 3 nights in the cardiovascular intensive care unit, 4 nights in acute care, and so on. After we submit that, we get a denial from the insurance company that itemizes what the reasons for the denial were and what the amounts for the denial were, but not what was actually denied. So we literally say, oh, medically inappropriate, denied $7,600. But we don't know what they're calling medically inappropriate. And we have people at our hospital that are looking through the itemized bill we sent to figure out which parts of it could add up to that $7,600 so that we could appeal or at least understand what the denial is. And that process goes back and forth with both sides using AI from the same companies against each other until it culminates in us literally mailing a box of paper to this insurance company's warehouse where
Wow.
they will, in theory, review it and then give an honest adjudication if it's a claim that should be paid.
Wow. It sounds like a huge waste, just a waste of resources, paperwork, dueling LLMs. I picture somebody with a sword, just sword fighting over the whole thing and crazy.
One of my
I sorry, go ahead.
One of my good friends and colleagues, Barack Richmond, likes to liken it to that stars on, stars off Dr. Seuss book about the Sneetches,
Right.
where
Yes.
both sides are paying the same technology company in this arms race to deny bills and contest the denials and so on.
That's crazy. So how do these inefficiencies ripple down to patient outcomes?
Well, so I think this diabetes example is a perfect one. We have now over 300 patients in this program that are really receiving incredible benefits of having a continuous glucose monitor, send their data to our care team, and our care team reach out to them as soon as there's an opportunity to help them improve their management. We have over 1,000 patients at Stanford that could be benefiting from something like this, but without the ability to bill for it, as any business needs to do to
Sure, of
maintain a
course.
sustainable service, it drastically slows that access. And then beyond our institution, there are diabetes centers all over the country that are incredibly excited about this work. Many of them sent a physician and a certified diabetes educator representative to fly out to Stanford to learn from our clinic. And almost every single one of them, the number one barrier and problem they had was, how did they get the funding and the resources to create and transition to this care model, which once it's up and running is better outcomes and lower cost. But without the ability to bill for that care, it's hard for them to make the case to their institutions to get the resources to make the change.
Wow. So if we had 2 hours, I would ask you, why are healthcare companies wanting to increase delays and cost of care? But we won't even go there. You probably can't answer this, but why is this still happening? The delays in approval and reimbursement.
Well, I like to go back to Nobel Prize winning economic theory from more than 50 years ago now. But basically, when an industry has a certain type of government regulation, it's often the case because that's the kind of regulation that industry wants. And
Mhm.
so my hypothesis is that the insurance industry wants to maintain the current levels of complexity and fragmentation as a moat against competition.
Yeah, absolutely. And I think we're going to let's get into that in a couple of minutes because that's a big thing. So in a system that's really designed to delay care, is that a byproduct or is that just a bad process by design?
Yeah, so remember I was saying before, I think all of these are just symptoms of the root cause.
Yes.
So the root cause, I think, is this intense fragmentation and complexity that's a barrier to competition. And the delays in care are to some product, I think actually mostly are just a natural result of that fundamental underlying complexity. And then, of course, a little bit at the margins, it is useful for health insurance companies to be able to pay out a little less in any given quarter or year so that their profit margins satisfy the kind of stock analysts to whom
Wow.
they essentially report.
Yeah, exactly. Okay. You've also made comparisons between healthcare and industries like mortgage lending. What would healthcare look like if we adopted more of their process of standardization?
Yeah, so this is a great example also from collaborators of mine, Kevin Schulman and Stefano Zenio, where if you go back to the 60s, every bank teller in every town and every bank in every state would just have their own, often ad hoc process for figuring out, hey, can you afford this house? Should I give you a loan or not? And it made everything slower and more complex and incredibly opaque, which is like our healthcare now. And then Freddie and Fannie Mac, which were private companies overseen by the government at the time, led a move towards let's create standardized instruments. Let's create a standardized loan package so that now we recently bought a house. We went online, we told it our credit score, filled out 7 questions, and then we just had essentially unlimited options for, okay, do we want, 10, 20, or 30 years? Do we want an ARM or a regular mortgage and so on? And each of those would instantaneously translate into our monthly payments, down payments, etc. So if health insurance contracts move to the same kind of uniform standardization, all of the stuff that's happening now could still happen, but mostly it could be done by algorithms talking to each other instead of somebody at the hospital picking up the phone, calling somebody at the insurance company,
Right.
reading the medical record number one digit at a time, and so on.
A lot of waste. So why are we already doing it, David?
I mean, I think the entrenched interests of the insurance companies are incredibly powerful. They're very well financed. They're very motivated to
Yes.
preserve the consolidated market and the barriers to entry.
Yeah, absolutely. I think that's key. You also said that a part-time grad student with an LLM could write better contracts. How does that really reflect on the current state of insurer negotiations?
Yeah, thank you for bringing that up. So, fantastic graduate student, Aya, heard me talking about this in class and said, can we try to make a proof of concept that you could translate these current complex contracts into something simple? Because one of the standard claims from insurance companies is the contracts need to be this complex to create all this value and customization. And we just thought, okay, as a proof of concept, could we code all of the prior authorization rules from large various insurers into one simple algorithm that would have the exact same rules they currently have, but instead of 100-page long PDFs, just as code that a computer could interface with? And she did this, and it took far less effort than we
Wow.
would have imagined. And there was far more common structure between the insurers than you would expect if you believe the claim that they're so beautiful and intricate to create value that they must be totally different. There was, however, a huge amount of variation in what the different insurers require prior authorization for, which is not what you would expect if prior authorization rules were really evidence-based and designed to minimize harm to patients or minimize inefficient, low-value care, because then there'd be a lot more consensus among the insurers when it wasn't necessary.
Yeah, absolutely. And there should be. I mean, we really essentially have five big major insurance companies. And then, of course, many employers are self insured, either through one of these companies or a private TPA. So it should be standardizable for sure. So, who's really benefiting from all this inefficiency? And is there really any incentive to fix it?
Yeah, well, I think on one hand, the insurers benefit by reducing competition. On the other hand, all sorts of middlemen benefit. And now you see more and more lawsuits bringing to light these unscrupulous practices where the information asymmetry between the middlemen and the employers they're selling to or the hospitals that they're not paying benefits them to be able to keep money that either then should have been paid out to a hospital or that they were paid by an employer for reasons they shouldn't have been, many of which you've given great examples of on your show.
Yeah, thank you. And we see it a lot in the PBM industry. I was speaking to Julie Selznick a few weeks ago about when Cigna purchased Express Scripts in 2018. They bought it for $67 billion. Before that, and I don't remember these numbers exactly, but I'm pretty sure that their profit before was 48 billion. They bought Express Scripts for 67. Their profits the next year were 153 billion. So they tripled just by buying this. And with the medical loss ratio rules, of course, the insurance company can't make too much profit, but it doesn't say the PBM that they own can't. So it's kind
Yeah.
of a shell game where they just move the profit around.
Yeah, exactly. Having this vertical consolidation and
Exactly.
opacity at each step. Well, if you own more of the vertical stack and can benefit from the opacity at each level, there's probably ways to benefit even more.
So, what percentage of the total healthcare spend do you think is due to administrative waste in billing, administration, et cetera, et cetera?
So this is something that lots of people study and do fantastic empirical work on. And so I think there are two really important different notions. One is just in the current system, waste, and different estimates put that between 300 and 400 billion dollars per year. And it's hard to always differentiate between waste, fraud and abuse,
Sure.
unnecessary duplicative care,
Right.
but that nexus specifically tied to billing. And I think that's a lower bound. What I think is interesting is not just thinking about the waste that could be eliminated, but the savings you could achieve if you transformed the system to a genuinely more standardized algorithmic one like most other modern industries. And there, I think there are savings on the order of $1 trillion per year, because healthcare administration overall consumes $1.6 trillion a year.
Okay. Healthcare administration is 1.6, and that's of approximately 5 trillion, right?
Exactly, yeah.
Yeah.
So this is both the costs and profits of the insurance companies doing what they do, and the costs that the physicians and the hospitals have to bear to interact with both private and public insurance. The huge amounts of physician time spent on coding things only for billing, not for clinical care, and the huge departmental staff and resources that are, again, entirely for coding and billing, not for any kind of care delivery.
Right.
So if you take that 1.6 trillion, again, when you get into these numbers, of course, these are estimates with wide ranges, but then you look at, okay, can we transform that? There you could talk about savings of $1 trillion.
$1 trillion. It's sad, but it's amazing. Unfortunately, I can't say that it's surprising. What would be the one administrative policy that you would eliminate tomorrow?
So the totally custom, ad hoc, different for every single health plan and hospital contracts. I think the foundation of how businesses transact with each other is the contracts. And there is no reason why all of the ways that insurance companies generally want to add value by preventing low value care or ensuring high quality shouldn't be encoded in simple algorithmic ways. So for example, you come to Google if you want to sell them your insurance plan and say, okay, here's our insurance plan. It's a small Python file, and you can take it and run it against your claims last year. And then you can see how much would it have cost you, what kinds of things would have been approved or denied based on your preferences of how you want to set up the plan. And that should be the basis of interaction. And then analogously, for that clear data-driven communication with the employers, you would simultaneously have clear data-driven communication with the hospitals and healthcare providers, where you say, okay, this is the data that your algorithms should submit to our algorithms. These are the rules. This is how we'll pay you and when, and so on.
I did a survey years ago, David, 10 plus. I surveyed about 4,600 private physicians, and I asked them how many percent of your patients are Medicare versus Medicaid versus insurance versus private pay, and how much you get per visit, and et cetera, a whole bunch of stuff. And I need to pull that survey out and dust it off. Interestingly enough, the private pay patients were the most profitable because there's less administration required. But here was the really interesting thing. Medicare patients had the most visit per patient per year. Not surprising. They're over 65. They're going to visit the doctor more. The second highest group I thought would be Medicaid, but it was actually private pay. They had the second most. And we did a focus group, and what they told us is that I leave the doctor's office educated, not medicated. So that was very, very interesting. And we looked at other industries that had similar statistics. And in veterinary medicine, which is way different than doctors, MDs, they had the difference in the makeup. For a doctor's office, they had 6 people on average in private practice, 1 physician, 0.5 of a nurse practitioner, et cetera. And then 4.5 people billing, administrative. In the veterinary's office, they had 1 to 2 vets, 3 vet techs, and 1 administrative person. So it just, showed that waste. And I've got to pull that out again.
Yeah. There was a great paper that I do more mathematical, theoretical modeling work with my colleagues, Barak Richman and Kevin Schulman. They do empirical work like visiting other countries with hybrid, multi-payer, government and private insurers. And there they tried to interview somebody to get a little more detail about how they can be so efficient administratively. And the person said, oh, I'm sorry, for my 1,000 bed hospital, I only have 6 people that work in finance, and we're all too busy right now to give you this interview.
Wow, really? What's the one tech tool or reform that could slash red tape without waiting for legislation?
So right now, health state commissioners and Health and Human Services, they already have an incredible amount of authority to regulate health insurance at the state level and at the federal level. So you don't actually need legislation. You just need political will and focus to move, in my opinion, standardized, rational contracts that computers could talk to each other about instead of people having to talk to each other about over the phone and fax.
So, last question. If you had 60 seconds in front of a hospital CEO, what would you tell them about fixing internal waste?
So right now, it's incredibly hard for you as the CEO to invest in efficiency because you have such a fragmented market of insurers. I'd recommend, and this was an idea from our Chief Financial Officer, Dana Herring, to start with your public plans. They're often the most complex to administer, but also the most willing to work with you to reduce complexity because they're not trying to prevent competition from others. And if you can find partners that are willing to kind of end the arms race of claims and denials on both sides and move towards simplification, county plans and other public state plans may be a great starting point.
Excellent. Excellent. Well, David, thank you so much for bringing clarity to the chaos. Before we wrap up, if people want to learn more, follow you, follow your work, connect with you, what's the best way for them to do that?
My research group is at surf.stanford.edu. If they look that up, they can find my email, my papers, and reach out to me.
Great. So to everyone listening, healthcare waste is not invisible, it's just ignored. But when we expose it, we can do better. I'm Ralph Weber, the Benefit Whisperer. In this episode, gave you something to think about. Subscribe, share, or reach out to me, ralph@thebenefitwhisperer.com, or call 832-924-3330. Let's keep peeling back the layers because this system will not fix itself. Thanks again, David, for being on the show today. And we're going to bring you back for another episode because what you have to say is just so amazing.
Thank you for having me.